Welcome to Oncology Radio. We are bringing you the latest information in the arena of oncology. Every episode brings you a new Maryland Oncology Hematology physician host, along with special guests in cancer research, new trials, cancer treatment, nonprofits, and cancer care. Maryland Oncology Hematology is broadcasting Oncology Radio from one of our 14 locations throughout Maryland. You can find Oncology Radio on Spreaker, iTunes, Google Play, Spotify, and iHeartRadio. So stay tuned and welcome to Oncology Radio.
Good evening, everybody. My name is Dr. Ravin Garg. I'm broadcasting live from Annapolis location of Maryland Oncology Hematology. Welcome to another episode of Oncology Radio. I have the distinct pleasure of introducing Dr. Vincent Lam. Dr. Lam is an assistant professor of oncology at Johns Hopkins Hospital. And despite being very young, he's already director of the Esophageal Cancer Research Program. We've shared many patients with Dr. Lam over the years. He's a wonderful clinician, wonderful person. So we're very excited to have you, Dr. Lam.
Great. Thank you so much, Ravin. I'm so delighted to participate in this podcast.
And thank you for coming. I just was hoping if you could tell us about yourself, where you grew up, about your family, if you don't mind.
Sure. I hail originally from the West Coast, from Seattle specifically, and went to college at the University of Washington. In fact, interesting fact maybe is that medicine is actually a second career for me. I studied computer science as an undergrad and worked in Silicon Valley actually for almost 5 years prior to coming to medicine, developing internet routers actually. So, but had this epiphany to go into medicine and did my training, my medical school at UCSF, and then eventually made my way out to Maryland, at the University of Maryland for my hematology oncology fellowship. My wife and our kids fell in love with Maryland. We had a little detour after fellowship where I took my first faculty job at MD Anderson, and had a few very just excellent years there, but an opportunity came up to come back to Maryland. And so I grabbed it, and here I am working with Julie Bramer and the rest of the thoracic group here at Hopkins.
And Dr. Lam, it's a fantastic group. And I actually did my fellowship at MD Anderson in Houston, and I met my lovely wife there. So I also had fond memories. So was there something about oncology in particular that drew you to it? I've had a couple, I remember in med school, I had a couple classmates who had different careers in computers and business, and they meandered their way into medicine. But was there something in particular about oncology that called you to it?
Yeah, it's interesting. I just, as you know, Ravin, as you go through training, there are, various factors that sort of impact what area or specialty that you may decide to settle on. And for me, it was really the patients. I just found that, in my rotations through the oncology clinic or the inpatient service, I really gravitated towards, the cancer patients. Initially, it was really more, or a lot of it was the sort of the end of life interactions. We had a very strong palliative care program and training, during med school. And so I really saw a lot of, meaning and value in terms of being a physician, for patients in that situation. But in general, it was really just the patients that really grabbed me in terms of their stories and the different pathologies and sort of the vast diversity of cancers. And then as I learned about the field more, the opportunities for research really were was the thing that really sort of sealed it for me in terms of just being able to potentially combine my background in computer science and background in informatics or big data analysis, with this emerging genomics, cancer genomics field.
Because I think that sounds wonderful, and I think it's a special field. I agree with most everything you said, about why I went to oncology too. So I did have some questions. Given your wonderful expertise for lung cancer and esophageal cancer, I did have some questions, and I wanted to focus more on esophageal cancer for today's podcast. And I think that from the lay public, not as much is known about esophageal cancer as perhaps, let's say, prostate cancer or breast cancer. And there's a variety of reasons for that. We don't really have a screening modality per se for esophageal cancer. But I was hoping from a macroscopic perspective, if you could kind of talk about squamous versus adenocarcinoma that's localized in terms of how you would approach let's say a T3N0 localized squamous cancer versus adenocarcinoma. Maybe talk about the cross study and how that perhaps influenced your management of patients.
Sure. I mean, I think just to take a big step back, I want to sort of pick up on that point in terms of just the visibility of esophageal cancer. As you know, Ravin, at Hopkins, our setup is a little bit more of a traditional setup in that we see esophageal cancer and GE junction cancer in the thoracic group, whereas gastric cancer is seen in the medical oncology GI group. But just as an entire entity, the gastroesophageal cancers, I think, are a little underappreciated. But it's striking because, combined esophageal, GE junction, gastric cancer, these gastroesophageal cancers account for, a tremendous amount of mortality worldwide. In fact, it's the second highest, group of cancers in terms of mortality in the world. So it's clearly, a prevalent disease type that a lot of us see, especially in the community, in our practices. So. And in terms of the differences between squamous and adeno, they're really two separate diseases. So for instance, squamous is really found generally in the upper esophagus or the mid esophagus, though can also be found in the GE junction at times. Whereas adeno is really more distal esophagus or GE junction. The risk factors for squamous and adeno are different as well. So as you know, squamous is really more, at least in terms of established risk factors, smoking and alcohol are really sort of primary drivers, whereas adenocarcinoma is really risk factors. They are really more like obesity or reflux disease, gastric reflux disease. So, and then the epidemiology are very different as well. Worldwide, squamous is really most prevalent, especially in Asia and other parts of the world. But in the US and in Western Europe, we uncommonly see squamous these days, and it's really more adeno. And so that actually, the fact that they're different disease entities really impact how these are treated. And so in general, squamous esophageal cancer is really treated with chemotherapy and radiation combined as per the cross paradigm, as you mentioned. Whereas with adenocarcinoma, there's actually, two options. You could either, for instance, for a GE junction adenocarcinoma, you could either use the cross paradigm, or there's actually a perioperative paradigm, which is the FLOT, using, per the FLOT 4 trial. So those are both used, and whether chemo-RT or perioperative paradigm is used, I think often depends on sort of local institutional practices and sort of strengths.
And Dr. Lam, in terms of for the cross regimen, I know they gave weekly carboplatin and Taxol. I do know that in the guidelines and some thought leaders in the field will advocate for FOLFOX to give with the radiation versus weekly carbotaxol. Do you have a preference for one versus the other? Like as an example, one thing I've heard is some will posit that FOLFOX may offer more systemic benefit, more so than the weekly carbotaxol, but no head-to-head comparison that I'm aware of. But do you have a practice pattern or a strong opinion on what regimen might be better?
Yeah, it's one of these sort of classic tough questions in gastroesophageal cancer in which we have to operate in in a gray area. You're right. We're hampered by the fact that there's no head-to-head. I tend to favor FOLFOX chemo-RT when feasible. So, unless the patient is a little bit frail, I actually do tend to favor FOLFOX chemo-RT. My thinking has evolved sort of on this a little bit. But yeah, so why do I favor FOLFOX chemo-RT? Well, a couple reasons. One, if you look at the cross trial, the rate of recurrence overall is fairly low, although one can't really escape the fact that even despite good multimodality care, we only cure, as in a 5-year overall survival, about 50% of patients. But in patients that do recur on the cross trial, or did recur on the cross trial, about 80% or so of the recurrence is distant. So, lending credence to the intuition that for many of these patients that are thought to be curable, these resectable patients, are perhaps actually not curable. And so maybe this was real, a lot of locally advanced esophageal cancer is actually a systemic disease that needs to be treated with more systemic doses of chemotherapy up front in order to potentially increase your cure rate and, address any potential micrometastatic disease that may be present at the time of diagnosis. So that's sort of the rationale for using more systemic doses of chemo as opposed to radiosensitizing doses of just weekly carbotaxol. We do have, a lot of people have pointed to a small randomized phase 3 study, the CALGB 8803, that was done several years ago, that did not specifically try to answer this question, but it really looked at whether or not a paradigm of switching your chemotherapy based on PET response after an initial period of induction chemotherapy would be helpful. And in that study, they used the induction regimens were FOLFOX versus carbotaxol. And so it's a little bit of a complex study in terms of its findings and its endpoints, but the bottom line is it was not powered to look at this particular question of is FOLFOX better than carbotaxol, and also it uses an induction approach, which is not standard per se, but numerically it looked very convincing for those of us who like FOLFOX chemo-RT that for instance, the path response rate for the patients who got FOLFOX all the way through was something closer to 40%, whereas the path CR rate for the carbotaxol group was something closer to 20%. So I think there's a lot, there's a good basis for using FOLFOX chemo-RT. Obviously, the downside is potential toxicity. And, of course, we don't want to do anything to jeopardize a potential curative window.
So, Dr. Lam, I thought that was a brilliant point you brought up with the cross, with the preponderance of recurrences being distant. Yeah. And so hypothetically, going to that point, if let's say we had a patient who's 55 years old with a GE junction adenocarcinoma, and radiographically they had local regional disease, but they had a lot of bulky lymph nodes. In the spirit of wanting to get better systemic control, would you argue more for perioperative chemotherapy with a flat regimen for that patient, more so than chemoradiation followed by surgery? Or do you think it's still an argument could be made for like a bulky lymph node, GE junction, we ought to still offer chemoradiation with surgery?
Yeah, that's such a key question, and one that, we have ongoing trials in Europe to try to answer, really sort of the debate between FLOT versus cross, and what may be more effective for these, GE junction adenos. But in a patient that, like you described, with bulky nodes, I do think that there's true equipoise now in terms of a chemo-RT approach versus peri-op until these data come out. But for somebody with bulky nodes or a sort of significant tumor burden like that, I would definitely favor a FOLFOX chemo-RT approach if one were to use, sort of that chemo-RT approach.
That makes perfect sense, and thank you.
Yeah.
So, Dr. Lam, patients will ask us all the time about immune therapy, and I'm going to talk about metastatic disease near the latter part of our podcast. But I was struck by this Checkmate 577 study, but before we delve into the nuances of that study, I was hoping if you could tell the audience how you would describe immune therapy, how it works, specifically the PD-1 inhibitors.
In general, how we talk about immunotherapy?
Mechanistically for a patient, how exactly does immune therapy even work?
Yeah, I mean, I think a lot of us use sort of the same analogies, but I describe it to my patients as, the current immunotherapies, the checkpoint inhibitors, the anti-PD-1 or PD-L1 therapies that we use. We use the car analogy in terms of using these drugs to release the brakes on your immune system to sort of unleash your immune system to find and fight the cancer. And of course, there's various other checkpoints that are being under investigation now in various trials. But the patients do seem to understand that analogy, and overwhelmingly, I think people are quite enthusiastic about the potential of immunotherapy.
So when we reactivate the T cell lymphocytes, it's a very exciting paradigm that we have in oncology now for the past 10 years or so. So it's given a lot of hope for investigators like yourself and patients. So, one patient that I had the good fortune to share with you, and you were wonderful at helping manage the patient, was a 61 or 62-year-old male. He had T3N0 localized esophageal adenocarcinoma near the mid-esophagus. He got weekly carbotaxol and radiation. He went for surgery. He had a response, but it was a little bit subdued. He still had residual tumor, no lymph nodes. And then speaking to your point again, which was fantastic about so many recurrences are distant from occult micrometastatic disease, the question that came up was whether or not there was anything we could do on the back end for this patient to help prevent, God forbid, a recurrence. So we stumbled upon the Checkmate 577 study, and I understand it now has Category 1 evidence in the NCCN guidelines. Yeah. I was hoping if you can kind of tell us about that, and has that study changed your practice?
Yeah, absolutely. So Checkmate 577 is actually a global randomized phase 3 study that was led by my colleague Ravin Garg when he was here at Hopkins. And so we're really proud to have participated in that study. And it is indeed a practice-changing study in that, it is a study that randomized patients who were resectable, esophageal patients, both squamous and adeno, that were resectable, and who had residual disease in terms of their pathologic response. So anything short of a path CR. Those patients were eligible. And these patients were randomized to either a year of nivolumab or I believe it was placebo control, although I'm not positive. And the results presented at ESMO this past year were striking in that the primary endpoint was disease-free survival. And disease-free survival was something on the order of 11 months in the control arm and 22 months in patients who received the adjuvant nivolumab for a year. Overall survival is not yet mature yet, but just based on that difference in disease-free survival, that many of us think that it really is a given in this disease, this tumor type, that we would see an overall survival benefit in the future. And as you mentioned, it's in the NCCN guidelines, and it's actually our standard of practice now, and I believe will be rapidly adopted. Of course, with immunotherapy, well, actually with all the trials, but particularly with immunotherapy, and particularly in a tumor type like gastroesophageal cancer that has traditionally not responded as robustly to immunotherapy, the devil is always in the details, in that you have to look at which subtype, which subgroup of patients actually do benefit from this. So I think, we eagerly await the manuscript to see what the different, for instance, PD-L1 subgroups, how they performed and such, because it's not clear that everybody, especially, those with adenocarcinoma histology, really do benefit from a year of immunotherapy. So that's, I think, an ongoing debate. But as you know, Ravin, really the challenge has always been, or continues to be, trying to find the better biomarkers or better ways to identify patients that can benefit from immunotherapy.
Dr. Lam, thank you, and agreed. It's exciting, but we need to kind of get better biomarkers to predict. Yeah. And speaking of biomarkers, I would like to segue into stage 4 disease, Dr. Lam. And, unfortunately, as you know better than I, and unfortunately, many patients can recur with stage 4 disease, or they can present de novo with stage 4 disease. And that's always a very difficult conversation for us as oncologists, as humans, with any patient, because our goals of care might be more palliative intent versus curative intent. However, I still remember as a fellow, which long time ago, so I'm dating myself now, the results of the TOGA study was published looking at Herceptin with 5-FU platinum-based chemotherapy. And I remember the thought leaders in the field at MD Anderson and no doubt at Hopkins and everywhere in the country. It was really exciting because it seemed like there wasn't a lot of activity for gastric or esophageal cancer with biomarkers. So I was hoping if you could tell the audience about, HER2 positivity, and what other biomarkers in your own practice do you interrogate for stage 4 patients who present to you?
Yeah, I think that's, as a good segue to the metastatic discussion, to sort of close the loop on that adjuvant, sort of the adjuvant immunotherapy paradigm. I think it's going to be an ongoing debate in terms of trying to identify which patients benefit from immunotherapy, but I think in a lot of ways that debate is an academic debate, because these approvals, and we'll probably talk about for instance Keynote 590 chemo immunotherapy in a little bit, but these approvals are coming in and they're fairly broad, and so really oncologists are left with trying to figure out who best, might benefit from these, or just give it to everybody for which the label is indicated. And that's indeed the case in the adjuvant, setting. Approval is for everybody with residual disease, and even though not everybody may benefit from it. But the reason why I find it compelling to give it to everybody until further data can come out is because a metastatic recurrence is really, as you know, quite a challenging situation. And in fact, overall outcomes remain quite poor. And so if there's any chance that we can try to cure a patient or improve our cure rates, I think that's what we're all sort of just grabbing onto with these, adjuvant results. But in a patient that has stage 4 disease, you really sort of highlight one of the key areas that has experienced tremendous, activity and growth in terms of, advances in gastroesophageal cancer, which is HER2 positive, the HER2 positive subgroup. And so just briefly, HER2 positivity is really more prevalent in esophageal cancer as opposed to gastric, maybe on the order of 15% or so in esophageal cancer. And it's something that we do see frequently. And we're actually quite active in terms of our clinical trials in addressing, this particular subgroup, because it's probably the most promising subgroup in terms of new therapies. So in terms of first line gastroesophageal cancer or HER2 positive, the standard of care still remains the addition of trastuzumab or Herceptin with chemotherapy per the TOGA study, as you mentioned. But we have Enhertu, which is TDXD, a HER2 ADC that has shown very promising phase 2 results, and phase 3 studies in the first line and second line are ongoing, including at Hopkins. And then there's other monoclonal antibodies, for instance, margetuximab for the second line plus, and then also really novel compounds, of which we have one that should be opening up in maybe the next couple months or so, which is a dragonfly compound, which is a tri-specific, basically using HER2 as an anchoring mechanism to recruit NK cells and to try to enhance the innate immune response in this subgroup. So lots of really exciting novel agents coming down the pike for HER2 positive disease.
Dr. Lam, that's exciting. Dragonfly, that's really novel. It recruits the natural killer cells to kind of the proximity of the cancer cells.
So it's actually, they call it they call it a trispecific or a trinket in their terminology. But so it's basically an antibody, one on one side targeting HER2, the other targeting NK cells, CD16, I believe, and then with a sort of an activating cofactor included as well. So, at Anderson, I led cellular therapy studies for lung cancer and such, and so I think this is an area of immunotherapy that really is quite promising for a disease type like gastroesophageal cancer, in which traditionally immune checkpoint inhibitors by themselves really have had relatively modest response. And so really pushing on that more innate immune response is one approach that really seems promising, as well as like T cell therapies and vaccine therapies.
I think that's incredible science. That's brilliant. And Dr. Lam, one thing I was struck by is when patients, let's say, have a de novo HER2 positive metastatic disease, and we give them the TOGA regimen, and they recur. I remember there was a study called the Gatsby study looking at another antibody-dependent conjugate, TDM1, which is approved for breast cancer based off the Amelia study. And it was essentially a negative study when it was compared to a second-line taxane. I thought you brought up a wonderful point with trastuzumab deruxtecan, that it looks very, very exciting. Any theories as to why that trastuzumab deruxtecan looks incredibly promising, where TDM1 was a little bit of a washout? They're very similar in terms of being antibody-dependent conjugates, different payload chemotherapeutics to be sure. But any thoughts on that?
Yeah, I think a couple reasons. I mean, you bring up a great, reference in terms of the Gatsby study, and then we also have the Titan study. Using looking at lapatinib, also showing no benefit over in comparison to trastuzumab as a reference point. And I think a couple reasons for these findings. Number one, we do know that maybe even up to 60%, but although I think maybe in practice closer to 40% or so of HER2 positive patients actually lose their HER2 dependency, after frontline treatment, as measured by IHC or DNA amplification. And so, in the older studies like Gatsby and Titan, it's not clear how many of those patients actually truly had HER2 positivity, in the second line plus, for example, because this was not tested prior to enrollment on the actual study. And with the margetuximab studies, for example, they did test this and really did show that clinical benefit was correlated to the presence of true HER2 dependence, either measured by ctDNA or tissue, at the time of enrollment. The TDXD also did not, curiously, did not sort of confirm that the patient was still HER2 dependent by IHC prior to enrollment in their second line plus trial in Gastric 01. But post hoc analysis showed that about 30% of the patients on that phase 2 study actually had high HER2 expression at the time of enrollment, which probably is more enriched, or likely is more enriched than, for instance, Gatsby or Titan. The bottom line being, there's really clear emerging data to suggest that we should be rechecking HER2 prior to thinking about the next line of therapy for these HER2 positive patients, because, as you remember, because of the studies like Gatsby and Titan, the standard or the thinking really was that we don't continue trastuzumab upon progression in gastroesophageal, unlike in breast. But now, if, for instance, so my practice is to recheck HER2 positivity prior to even thinking about some of these studies that we have available here at Hopkins, but even as standard of care outside of a clinical trial, I would retest HER2 just to see if I should continue Herceptin, with a different chemo backbone. The second factor that I think probably leads to the improved efficacy that we see with TDXD is just, I think the ADC itself is just a better ADC with a cleavable linker that really leads to a lot of bystander effect. Also leads to some side effects, like, for instance, the pneumonitis or interstitial lung disease. That is a hallmark side effect of that drug. But yeah, so I think it is a better ADC as well.
Dr. Lam, I thought that was a brilliant point about retesting. I think that's something that's not as well thought of. That's a great point that you brought up. So Dr. Lam, to the credit of researchers like yourself and the Johns Hopkins team, I know in 2015 they had a wonderful publication, New England Journal of Medicine, looking at MSI high status, agnostic towards the tumor type, as being a wonderful predictive tool for the effectiveness of checkpoint inhibitor therapy like pembrolizumab. And that has approval kind of agnostic towards a tumor type for metastatic disease as MSI high. And also the FDA approved, if your tumor has 10 mutations per megabase, you can give single agent pembrolizumab agnostic for a tumor site. But let's say if you have a patient with stage 4 disease, HER2 negative, mismatch repair is proficient, so it's MSS, and the PD-L1 is elevated, let's say 10 or higher based off the CPS score. You had mentioned this Keynote 590 study, and I was really taken aback in a good way with the results. at looking at combining pembrolizumab with chemotherapy frontline, the CPS score has to be greater than or equal to 10, I believe. I was wondering if you could talk about, CPS score, what you think the study means, and has it changed your practice?
Yeah, I mean, there's a lot of great points, in that question there, specifically like MSI high or TMB high. And I think you didn't ask this particular question, but, one thing that I think has come up is, for those patients, MSI high and TMB high, should you actually just give pembro alone, in the front line as opposed to chemo IO? To your question about Keynote 590, so Keynote 590 is one of three actually three studies that were presented at ESMO this past year, looking at reporting out results from large randomized phase 3 studies of chemotherapy plus immunotherapy in the front line. And 590 is sort of relevant because it's actually the first to lead to an FDA approval. In fact, very recently, I think just last week or something. And as you mentioned, the study actually was positive. The primary endpoint was for CPS greater or equal to 10. And that was what the NCCN category 1 indication was for. But the FDA label is actually for all comers. So no CPS restriction, because this, while not a primary endpoint, the study was also positive for all comers, although to sort of, with a lesser magnitude. Again, to the point I was making earlier about oncologists being sort of put in a somewhat difficult position of trying to figure out, what to do, what's the best approach for their patient that's sitting in front of them, given, sort of this discrepancy. But yeah, so CPS is really critical in terms of a biomarker for immunotherapy and gastroesophageal right now, because it really is unfortunately the best biomarker thus far. Other than MSI, which is quite rare in esophageal cancer, less than 1%, and then TMB high, which is also similarly uncommon, but often, those are the patients who are either MSI high or, similar sort of histologies. I think in general, the breakdown in terms of CPS and gastroesophageal is really kind of like a third. So you have this privileged group of CPS greater or equal to 10, which I think very roughly represents about a third of patients. And then the rest are, are I would say moderate to mostly low PD-L1 expression. The difference in gastroesophageal cancer, as opposed to other tumor types like lung, and the reason why we use CPS is because there is relatively little T cell infiltration into the tumor itself. A lot of the, if there is PD-L1 expression, most of that is actually in the stroma and the surrounding immune cells. So PD-L1, unfortunately, is really the best biomarker we have thus far, and really has shown some utility in trying to tease out who benefits from these, checkpoint inhibitors. So in terms of Keynote 590, really, that's another situation where we really are very eager to see the actual data, the manuscript, to see how well the patients who were CPS greater or equal, less than 10, the low CPS expressors actually did, because they did not present these data at ESMO.
So, Dr. Lam, so until we have the manuscript, and your point was well taken, do you feel wedded to the concept that the CPS score ought to be greater than or equal to 10 before you'll integrate pembro with your chemotherapy frontline? Or are you willing to give it with, let's say there's no trial available, HER2 negative, and would you feel, let's say the CPS score was 2, would you feel comfortable without the manuscript offering pembro with the chemo frontline, or would you wait for the publication to come out?
Yeah, this is where, again, an intense area of debate in the academic circles, where I think actually a lot of, from a pure academic perspective, just feel a little unsettled about giving patients, giving this to all patients, sort of knowing the biology of, low CPS and, immune checkpoint inhibition in this disease type. But I'm in favor, in fact, of giving chemo IO for all patients until these data come out. Because, again, number one, as you know, Ravin, this gastroesophageal cancer is a very difficult disease in the metastatic setting from a symptomatic perspective. And so we know that not all patients, in fact, maybe even maybe around half of our patients in the first line metastatic setting don't actually make it to the second line treatment. So I really think that favors giving as much treatment as we can, that's tolerable by the patient, that has the potential for affecting a long-term durable response. We don't know whether or not those low CPS patients may benefit from this, but I think it's quite reasonable to give it until we see further data. And again, it's plausible that these patients may derive benefit because of, possible chemotherapy, immunotherapy, synergy, due to, neoantigens being released, or, sort of immunogenic cell death. So that's what I'm sort of, resting my hat on in terms of just encouraging use of this for everybody at this point, because I'm not sure, whether or not that patient in front of me, for many of the patients that I see, will be able to make it to the second line. And then also, for the patients who are low CPS, that, for instance, if you choose not to give chemo upfront, then you will probably end up using it in this, second line or third line setting. It's actually not even FDA approved. Pembrolizumab is not even FDA approved in the second line, actually, for adenocarcinoma. So you'd have to wait into third line formally. But let's assume that you give it in the second or third line. It's the response rates for monotherapy in that setting for those patients is actually quite low, probably less than 10%. And so, I don't know if that really buys you much to sort of hold off on giving the monotherapy, giving the immunotherapy later on. I think maybe the practical consideration there is, do you even give immunotherapy at all for those patients?
And Dr. Lam, not to leave out nivolumab, I understand based off Checkmate 649, if your CPS score was 5 or greater, there was also really compelling data for offering chemotherapy with immune therapy. Do you think there's equipoise between the nivolumab data and the pembrolizumab data? I know the CPS score was different. I know they have different assays to even monitor or adjudicate what your PD-L1 status is, so it's very confusing. But in your own headspace, do you find them largely interchangeable drugs, or do you happen to favor one versus the other?
Yeah, at least between these two studies, there's really no, again, with the sort of the dearth of actual details from the study available at this point, as best we know from the public, the presented data, we don't really see any discernible difference between the two regimens. As you mentioned aptly, it's very tricky to try to actually tease out differences between these studies because they use, for instance, different PD-L1 antibodies. And even the way they present it is kind of tricky because, they'll present something as PD-L1, meaning TPS, and then a subgroup is actually CPS. So there's a lot of intricacies, but I think the bottom line there is they seem fairly interchangeable. I think practically, it's really, there may be some considerations there. So, for instance, Keynote 590 was actually done with Cis5FU, but some, including myself, we've sort of considered FOLFOX interchangeable with in terms of those results. So whereas Checkmate 649 was a FOLFOX or a CAPOX based study. So it's really, so Checkmate 649 is sort of ready built for sort of the way that we, I think a lot of us generally, practice in terms of metastatic chemotherapy schedule. Whereas with the Keynote 590, you would actually have to sort of make a few extrapolations and actually use FOLFOX instead of Cis5FU. And then actually you would use Pembro in a Q6 week dosing to really stick with the, to really stay in phase in terms of your visits.
Dr. Lam, this was an outstanding talk. Thank you. I wanted to thank the audience for listening. And Dr. Lam, you've been a wonderful partner for us, an advocate, a great researcher, great clinician. So we're very fortunate to have you in the area to refer patients to. So I wanted to thank you for coming to Oncology Radio. So good evening. So everyone have a good night, and please join us for the next Oncology Radio session.
Thank you so much, Ravin. Thank you.
Thanks for listening to our latest episode of Oncology Radio. You can find the broadcast on Spreaker, iTunes, Google Play, Spotify, and iHeartRadio. You can find more information about our physician hosts from Maryland Oncology Hematology at www.marylandoncology.com. Subscribe to our show on Spreaker at www.spreaker.com/user/Oncology Radio. And remember to follow the guidelines and get your cancer screenings for the best defense against cancer.